We described the pharmacokinetic and pharmacodynamic properties of anti-mycobacterial agents, and we differentiated between latent tuberculosis and active pulmonary tuberculosis infection. Now, let's initiate a medication regimen in a patient with latent tuberculosis infection. Here are the recommendations from the 2020 CDC guidelines for treatment of latent tuberculosis infection, which really you can think of as prophylaxis since these patients don't have an active infection. Because the patients with HIV are at high risk of mortality from tuberculosis, the evidence for treatment of latent mycobacterial tuberculosis is really based on whether the patients have HIV or not. In general, there are three regimens that are considered preferred by the CDC. The first one is a once weekly combination of isoniazid and rifampin. And I should say that historically, the treatment of latent tuberculosis used to be 9 months of isoniazid monotherapy. So anything else is really in comparison to what used to be the standard of care, which was 9 months of daily isoniazid. So the preferred regimen, the first preferred regimen is the once weekly isoniazid plus rifampin, and compared to 9 months of isoniazid daily, it is really associated with less hepatotoxicity. So significantly less hepatotoxicity and high efficacy. So because of high efficacy and less hepatotoxicity, this regimen is really considered first line. And because it's once weekly, it's really easier for adherence. Now, there are some downsides to this. So, for example, even though it's once weekly, it has a high pill burden. So there are 10 pills that the patient has to take once a week. And it's relatively more expensive compared to the other options here. So sometimes the cost can be prohibitive. And another thing is that historically, this combination that's given to patients once a week, it was given as directly observed therapy, meaning that the patient actually had to go to their provider once a week, so the provider can actually observe the patient take this combination. And that was really to ensure that the patient is adherent. And that could also be costly. So if you have to make a weekly follow-up meeting with your provider, that's going to add to the cost. Now, in recent time, there was a study that showed that self-administered therapy, meaning that you do not need to go to your provider's office for them to observe, taking this regimen, was actually non-inferior to directly observed therapy in the United States. So now it's actually okay if the patient, takes this regimen based on self-administered therapy. So this recommendation is a strong recommendation for both HIV negative patients as well as HIV positive patients because of the good evidence in support of this regimen for both populations. Now, the second regimen that's also considered preferred is a once daily monotherapy with rifampin. And this monotherapy would have to be for a total of 4 months. And compared to what used to be the standard of care, which was 9 months of isoniazid daily, this regimen is also less hepatotoxic, so significantly less hepatotoxicity. However, rifampin is a strong inducer of CYP enzymes, so this regimen is considered with many drug-drug interactions. And because it's monotherapy, if you, for some reason, miss the patient having an active TB, or if the patient has subacute TB, they're more likely to develop resistance to rifampin if this patient takes rifampin monotherapy. But in general, for latent tuberculosis, rifampin monotherapy is very efficacious. So it is a strong recommendation for HIV negative patients. Unfortunately, there's really no evidence to support this recommendation for HIV positive patients because it has not been studied. So it's not really recommended for HIV positive patients. Now, if someone cannot take rifampin because of drug-drug interactions that are contraindicated, and if that patient also does not qualify to take isoniazid because of hepatotoxicity, It is recommended that rifabutin, another rifamycin, can be substituted for rifampin because rifabutin has less drug-drug interactions compared to rifampin. And the third agent that's considered preferred is the combination of isoniazid and rifampin once daily for 3 months. And this is not a strong recommendation. It's a conditional recommendation. It is, compared to 9 months of isoniazid, this has less hepatotoxicity. It still has isoniazid, which is hepatotoxic. So, daily isoniazid can lead to hepatotoxicity. So it is definitely more hepatotoxic compared to rifampin monotherapy. And because it's for 3 months, discontinuation due to adverse effects do occur in patients. So for that reason, it's not really a strong recommendation. And of course, it has rifampin in it. So if the patient has subacute TB or active TB and didn't get diagnosed, this patient can develop rifampin resistance with this regimen. And then isoniazid daily monotherapy is considered alternative, primarily because of the long duration of therapy. So you need at least 6 months of therapy, and the standard of care used to be 9 months of therapy with this, which leads to very high risk of hepatotoxicity. And a combination of long duration and hepatotoxicity led to low completion rate. So patients just stopped taking it because of the low tolerance and long duration of therapy. So for that reason, these are considered alternative.